Another, the so-called tropical ulcer of the legs. Vincent group of organism, look at the chronic type of ulcer, with some maggots, it is so chronic. And then bone changes, what are the bone changes, underlying bone changes? Periostal reaction, generally it is not thin linear periostal reaction, because it is chronic, thick type of periostal reaction with cortical thickening. Because the patient more or less takes rest, osteoporosis noted, osteomyelitis involving the marrow, ulcer osteoma, occasionally there is no osteomyelitis, only periostal reaction, cyclic, and then it fuses with the cortex, producing an osteoma-like picture. And of course, it is chronic malignancy, the ulcer can occur. Squamous cell carcinoma often. And then filariasis, Usheria bankruptcy in tropical countries. In some areas it is common. And how does it produce soft tissue swellings? Bone infection, not necessary unless there is a secondary infection. Bone is not involved by filariasis. But lymphedema, and with lymphangiograms, enlarged lymph nodes with obstruction to the lymphatics. Same thing in arm, it can occur in the knee. Diffuse soft tissue swelling is important. With the lymphangiogram, you can outline the obstruction of the lymphatics with these filarial bacteria. Lung infections. Unusual lung infections in tropics can occur from viral, bacterial, fungal, protozoal, and parasitic. Imagine, today with AIDS spread all over the world, unusual infections are not uncommon in AIDS also. All the tropical, non-tropical infections are encountered in AIDS patients. Measles. In spite of the vaccination, particularly in India, occasionally we get measles in children. What is the picture? Well, diffuse mottling, coarse mottling, leading to pneumonic patches. Radiology, the segmental arterial pneumonia, which is common in measles, is mainly due to bacterial, superimposed bacteria, not just viral. It predominates in the lower lobes and is usually accompanied by segmental atelectasis too. Primary measles pneumonia produces a reticular interstitial nodular pattern, not pneumonia, throughout both lungs. The pattern is sometimes described as radiating from the hila. Hilar lymph nodes are usually enlarged. Resolution in non-fatal cases occurs over several months. It takes months. A rare finding of mediastinal emphysema in 0.3% of cases has been noted. That is due to rupture of one of the alveolus and then extending interstitial emphysema, extending to the mediastinal and mediastinal air is present. That is mostly because of the cough. The incessant cough that these children get evokes, stimulates one of the alveolus to rupture, and first interstitial emphysema is noted in conventional radiographs. It is difficult, and then it extends to the mediastinum. That's how mediastinal emphysema produced. And true measles pneumonia is more common among children than adults, with underlying diseases such as malignancy and congenital immunodeficiency. Malignancy, for example, the child has got lymphoma or leukemia. Under treatment or without treatment, they can develop measles. The giant cell pneumonia usually develops at the time of eruption of rash or slightly before, but may be delayed up to 35 days. In patients who fail to develop specific measles antibody. Then chickenpox pneumonia. You can get patchy opacities, nodular opacities. Look at the picture on the right side. Diffuse interstitial pneumonia, as some of the interstitial infiltrates are coalescing, you can get a picture of an alveolar type of pneumonia also. Some of these, even after treatment, you get what is called multiple calcific densities throughout the lungs. Particularly it is common, not in childhood pneumonia. Childhood chickenpox pneumonia generally resolves. But in adults, it results in multiple calcific densities scattered in both lungs. Chickenpox pneumonia, radiological differential diagnosis, in children particularly, hyaline membrane disease, haziness, aspiration pneumonia, transient tachypnea of newborn. Second, pneumonia simulating cytomegalovirus infection, E. coli, influenza, and the rest of the things. I remember this young girl, about 16 or 17 years old, comes with breathlessness, dyspnea, palpitation. And when we saw and took the film, already she's, both lungs are in the respiratory distress syndrome. She's on ventilator. And you see the air bronchogram in the consolidated lungs. This is one of the pictures of the entire spectrum. ARDS, acute respiratory distress syndrome. Often, we don't have, in villages, they reduce the speed of the car. There are no speed breakers. The buffaloes and the cattle act as speed breakers so that you are protected from high speed. Now we come to the Legionella pneumonia. Generally, the organism comes from air-conditioned rooms, from the air conditioner itself. This 43-year-old person comes with cough and fever. Lo and behold, we just a radiograph, bilateral patchy opacities. And regular community-acquired pneumonia is common because these people go to religious melas and multiple public meetings, political meetings, and public gatherings, and acquire infection. Regular consolidation of the lung. With consolidation, there may be some airlessness. That's why there is some collapse of the right upper lobe. And these lead to abscesses, pyogenic, bacterial, positive or negative, gram-positive or gram-negative bacteria. Classical abscess, one on the left side with an air fluid level. And the one on the right side, in spite of treatment, there is irregular necrosis, border of the abscess, necrosis. One has to think in terms of gangrene. Maybe the vessels are involved. And then multiple abscesses are restricted to the right lung. This is also consolidation in the right upper lobe. It's not atelectasis. But then the transverse fissure is bulged low below the right hilum. This is what is called bulging fissure sign, often seen in staphylococcal pneumonia in children or Klebsiella in adults. Actually, patchy areas of pneumonitis, consolidation in both lungs, you can call it bronchopneumonia, but in certain films there is central necrosis, multiple abscesses in staphylococcal. And another important finding in staphylococcal pneumonia is, apart from this space-occupying pneumonia, one of these may rupture and produce pyopneumothorax. On the other hand, if they heal in the healing process, they leave with a pneumatocele. The infective portion is disappearing, but the host capsule or wall will remain for some time and produce a pneumatocele. Eventually, they disappear also. Look at this 5-year-old child with high fever and then abscess with a meniscus sign. Meniscus sign, we know, often occurs in a fungus ball. This is not a fungus ball. It didn't move in erect and decupitous views. On the other hand, it is just an abscess and producing meniscus sign. It is not a hydatid cyst. And of course, as a child, you can't think of a malignancy. Eventually, this disappears, leaving a pneumatocele. Other infections, fungal infections, actinomycosis, Aspergillosis, blastomycosis, coccidioidomycosis, cryptococcosis, histoplasmosis, nocardiosis, and sporotrichosis. Some of these are common in other tropical countries, not so much in India. For example, histoplasmosis of the lung, rarely we see. If you see elsewhere, it simulates tuberculosis. Except effusion is not that common as in tuberculosis. Cryptococcosis, we have seen few cases where there is immunodeficiency. Coccidioidomycosis, also rather rare. Blastomycosis, rarely seen. It simulates actinomycosis. Aspergillosis of the lungs are common, either primary or secondary, or even allergic type of bronchopulmonary aspergillosis. When you think of aspergillosis, usually you think of a fungus ball. These are the two different cases where there is a central density and usually it's free floating with a chronic cavity. This cavity may be tuberculosis or any other cavity. Even in malignancies, we have seen a fungus bulb. Blastomycosis, nothing specific. There is pneumonitis and pleural reaction. Nothing specific to say it is blastomycosis. But laboratory-wise, and from the history, whether a man is dealing with soil or some other places, we can think of blastomycosis. Histoplasmosis, as I have said already, in India it is rare. It may simulate like coin shadows, calcified nodes, infiltrates. As I said earlier, it simulates tuberculosis. Cryptococcus pneumonia, rare again, usually pulmonary masses, single or multiple consolidations. So occasionally you can see wide spread nodules. Actually, central nervous system is more often involved with cryptococcus pneumonia, that cryptococcosis that we have seen. And in the lungs or in the mediastinum, lymphadenopathy may occur. Other lung infections, protozoal, pneumocystis carinii in children and adults, in immunosuppressed patient. Otherwise, toxoplasmosis, Entamoeba histolytica used to be very common. Metazoan infections, Loeffler syndrome, fleeting pneumonias, pulmonary eosinophilia, tropical pulmonary eosinophilia, simulating tuberculosis, paragonomyosis, rare, schistosomiasis of the lungs, usually it manifests with pulmonary hypertension because of the chronic interstitial fibrosis. Echinococcus, not so uncommon, particularly in India. Tropical pulmonary eosinophilia, diffuse interstitial mottling, nothing else. This is a 25-year-old woman, comes with dyspnea mainly, loss of appetite, low-grade temperature, and this blood picture shows 70% eosinophils. And then amoebic, pulmonary amoebiasis, pneumonitis with cavitation in the right base. Note that the right dome of the diaphragm in the lateral segment is not well outlined. That should indicate maybe there is some infradiaphragmatic pathology, such as hepatic amoebiasis or hepatic abscess. Now, several decades ago actually, we have found, and I have presented a paper on hepatopulmonary amoebiasis. And then upward enlargement of the liver. How do you diagnose? Elevation of the right dome. Impaired movements, we used to do a lot of fluoroscopy. Oral reaction, not necessarily effusion, and pleural effusion. Basal pneumonitis, atelectasis because of the breathing problem, diaphragm does not move. The abscess of the lung, pneumothorax because of the rupture, pneumothorax, and hepatopleurodbronchial fistula. I remember 2 or 3 cases, the patient is coughing up and bringing bile-stained sputum. And then what are the findings? And conventional radiology we are talking of. In those days, there is no ultrasound, no CT. Later on, we have found CT. And then conventional radiology, downward displacement, we used to do a barium enema, hepatic flexure down, displacement of duodenum to the left on GI series, displacement of kidney on plain films, pressure over fundus of the stomach, pressure over lesser curvature, rupture into pericardium, rupture into peritoneum, rupture into viscera. Also we have seen, and rupture into subcutaneous tissues. Hepatopulmonary amoebiasis. How can you diagnose? You have to suspect. There is no question of making a firm diagnosis. And then pleural effusion manifestation. And on screening, restrict of the movements of the diaphragm. Hepatopleurodbronchial fistula. First it starts as an abscess, and then it ruptures into the bronchus, and we have injected into the abscess contrast media. Notice the trace of the contrast into the lung abscess and then into the bronchi. The patient is bringing forth sputum stained with bile. Later on, recently you can have a CT or an ultrasound, which makes the diagnosis easier. Hepatic abscess on the left side has ruptured into the lung. Clinical picture on your left, the mass in the epigastrium. And also remember, in those days there is no ultrasonography or CT. On plain films there is a huge enlargement of the liver downwards as well as upwards. And then we used to aspirate and inject contrast medium. And for example, the huge abscess, after anti-emetic treatment, after say 10 days or 15 days, again you take a plain film, contrast shrunken. That's how we know the prognosis of the hepatic abscess. There is what is called primary pulmonary hemodialysis too. This is not common, but occasionally you see a pneumonic patch, most often on the right side. Nondescript type of patch of pneumonitis. Trophozoite with phagocytic RBC. Now we come to hydatid cyst. Somebody else is talking about hydatid cyst, so I'm restricting to just one or two films. Rupture hydatid cyst. Note the linear atelectasis and also the so-called camelot sign, water lily sign at the bottom. Lobulated type of densities. This is of course density. One thing I want you to remember is look at the lower border of the density, rounded opacity. It has got a tit-like, just a little dip into the lung. That is supposed to be classical of hydatid cyst. Coccidioidomycosis, rare as I said, but I have seen in my experience elsewhere. And it can also chronic, fungus ball. Apart from the patchy areas of pneumonitis and cavitation, the right lower lobe, you see another meniscus sign, fungus ball, secondary aspergillosis, because of the chronic cavity. Dracunculosis medinensis, what has that to do with the lungs? It never goes into the lungs or viscera. Only one or two cases are reported where it has migrated into the knee joint, from the cutaneous to the synovium. But then, not common, but at one time, in villages, there are water, only one deep well. There used to be step well, they call it, steps they make, go down and fetch water up. And gravid female migrates into the soft tissues of the leg because they go down into the well, producing ulcers from which larvae escape. Again reinfected. This may migrate to any soft tissues. But radiological interest is active guinea-worm you can't diagnose. Through the ulcer you may clinically see it. But calcified guinea-worm, in fact, the film on your left side, somebody suggested old tuberculosis. But then if you take a lateral film, that is in the back, soft tissues, you can see the coiled calcified worm, which is classical of a guinea worm. It is not cysticercosis. Cysticercosis shows a cigar-shaped or a cylindrical type of density. Paragonomyiasis, in my extensive lectures abroad, I have picked up this one and proved paragonomyiasis. Nothing classical about the radiographic picture. Actinomycosis, of course, this we see not often but occasionally here. Three major things on a plain film of the chest we have to find: either pleural reaction, thickening, effusion is not common because it's chronic, reblation, sclerosis, periostal reaction, thickening, and then adjacent pneumonitis. These are the three radiological findings that strikes you, maybe it is actinomycosis. There need not be any fistula or synesthetes. And then occupational disorders. Still manually our granite workers are exposed to silicosis and pneumoconiosis, etc. In silicosis, classically bilateral patchy densities. Note the lateral margin of these densities, fibrosis, lateral margins are parallel to the thoracic cage. That is classical of silicosis, apart from calcifications and axial calcifications in the limbs, mediastinal and hilar nodes. Again, in tropical diseases, dyspepsia and peptic ulcers are common. One, they say malnutrition. Two, irregular type of spicy food. Smoking is common. And of course we know Helicobacter pylori is the common organism that may induce peptic ulcers. Classical example of a gastric ulcer, lesser curvature on the left side. You see the thick rind and so-called meniscus sign, That irregularity of the ulcer is due to maybe secondary infection by fungus because of the chronic ulcer, or it may be blood clot too, a specimen of the gastric ulcer. Duodenal ulcers, active and chronic, is an active duodenal ulcer. For these, you need an art of the radiologist to demonstrate the ulcer is an art. We have patients use spot films, various obliques techniques to demonstrate the ulcer. Of course, endoscopy has ruled out most of the frequency of barium series and upper gastrointestinal series. But still occasionally, radiologist is called, maybe there is hemorrhage, maybe the patient is unwilling to undergo endoscopy. In those cases, it is your duty, radiologist's duty, to demonstrate the ulcer with single contrast or air contrast. The pea-sized double density in the duodenal bulb is indicative of active duodenal ulcer. Of course, today we know Helicobacter pylori is the major etiological agent in peptic ulcers. Again, in tropical countries, particularly in India, rheumatic cardiac disorders are common. Rheumatic fever first, and then it bites the heart and licks the joints, the usual saying goes. In biting the heart, it may produce pericardial effusion, myocarditis, and valvular diseases, commonly mitral, aortic, and tracheal. In a plain film of the abdomen, classical findings are, first, the left atrial enlargement. The left ventricle may be small in mitral stenosis. Early left atrial enlargement. Left atrial appendix, that's the most important. Left atrial enlargement may be seen in other conditions, say left atrial myxoma and other conditions. But the appendix, how do you diagnose rheumatic heart disease on a plain film? There's what is called, Felsen has described, the third Mogul sign. Mogul means a bump. The first is aortic knuckle, second is pulmonary artery, the third is the left atrial appendix. Of course, the fourth is the left ventricle. On the other hand, occasionally you may see a double density in the heart due to left atrial enlargement. Sometimes you may require barium swallow. And if there is associated mitral incompetence, left ventricle is also involved. And tricuspid valve involvement is not rare. An ideal view in those days is barium swallow in the left lateral view of the chest, depression or impression upon the mid-third of the esophagus due to left atrial enlargement. And miscellaneous lesions of bone, stress fractures, the cultural activities, particularly the dances, the classical dances, or the modern dances are very common, so prolonged stress, unaccustomed activity, and repeated microtrauma produces some bone changes. Or what's called Bhangra dance in Punjabis, you can get a stress fracture. Note, you don't see the fracture line in the proximal end of the tibia, you see a dense line, that means already there is a reparative new bone. A traumatic fracture at that site is uncommon. Metatarsal heads, so-called Freiberg osteochondritis they used to call, are marched fractures due to prolonged stress upon the metatarsals. You can get not only the second metatarsal head, third, or even fourth, depending upon where the weight bearing is. Fatigue fractures, insufficiency fractures, and subchondral sclerosis, the so-called Freiberg's infraction, not infarction, infraction. Well, there is infarction also. There is ischemic necrosis. Again, classical dance, particularly in women, there is a stress on the fifth metatarsal, and you see periosteal reaction and cortical thickening. Early on, if the patient complains of some pain, the most sensitive thing is to do isotope scanning. It is highly sensitive, it may not be specific, but unusual areas of heart. Then you know it must be a stress lesion. I don't call it a stress fracture because fracture is gross. Stress trauma, microtrauma occurs, and to compensate that, there's a lot of new bone formation. And rare findings, somebody else is taking up tuberculosis of the GI tract, but I wanted just to show the corrosive poisoning with pesticide amongst farmers, very common, because of the crop failures due to nature failure, due to lack of rainfall or excessive rainfall, the crops won't come. They entirely depend upon their livelihood only on crops. In those days, especially now, pesticide swallowing is very common, and you see the ulceration of the esophagus and irregularity in chronic stage produces stenosis. One on the right side again shows multiple sinus tracts. It is not due to pesticide. It is due to the tuberculosis of the esophagus. Invariably, these people who have tuberculosis of the lungs, they swallow the sputum and foci of tuberculosis are implanted in the esophagus. And smoking is also common in tropical countries. And smoking, common oral cancer, head and neck cancer, laryngeal cancer, esophageal cancer, lung cancer, even bladder cancer. So, ladies and gentlemen, it is a long talk. And yet, I haven't covered most of the entities. The rest of the speakers will cover other things such as Hyderabad, genitourinary tract tuberculosis. I have confined myself mostly to the bones because osteomyelitis to diagnose early is very important. I have stressed upon that. And lung infections, some of them common, some of them are rare. Tuberculosis of this lungs, somebody else is going to talk. That's why I have not covered. So the saying is, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Robert Frost. And this tropical fruit is compiled by one of our friends from Vizag, Sumam. Thank you. And